Good evening, everyone, and welcome to this latest Facebook Live event. My name is Sam Ciotkowski. I'm the Sales and Marketing Manager at the JCN. I'll be running through just a quick intro and some housekeeping bits before we get started with the session, but that'll only take a couple of minutes and then we'll be good to go. So tonight's session is titled Overcoming the Fear of Wound Infection, and our speaker tonight is Luxmi Dhoonmoon. Hi Luxmi, how are you?
Hi Sam, thank you so much. Looking forward to it.
Luxmi is the Tissue Viability Nurse Consultant at Central and North West London NHS Foundation Trust, and today's session is sponsored by Flen Health, so a big thank you to them. Do make sure you check out all the links that will be posted on the slides and in the comments section, so you don't miss a thing. Please also do make sure you get involved with tonight's session. Any questions that you have for Luxmi, please do put them in the comments. We'll get through as many as possible in our live Q&A at the end of the event. And if we don't get through to your question, we will answer those in the next few days and post those on our website as well. Certificates will also be available. We'll post a link on the slides and in the comments at the end of the session. You'll be able to download the certificates, see the slides and see all the Q&A answers on our website in the next few days. Finally, do bear with us if there are any technical issues. I'm sure you're all aware we're still recording remotely. We shouldn't have any issues, but if there are, our team will be working behind the scenes and we'll get everything back up and running as quickly as possible. And that's all from me. I will see you in the Q&A, and I will now pass you over to Luxmi. Thank you.
Thank you, Sam. Good evening, everyone, and thank you for joining us tonight for the session on overcoming the fear of wound infection. And tonight's session, we will be looking at identifying the infection in the wound bed, which I know is a big part of most clinicians' role, especially in community or in the acute settings when you're managing wounds. We'll also be looking at the different stages when it starts from colonization right up to infection, understand the importance of managing infection effectively, and we will also follow by the use of some case studies using an enzyme alginogel as an antimicrobial. When infection, the facts, we all know about it, it's very painful and inconvenient for the patient. It also leads to an increased morbidity, which can lead to frequent risk of hospitalization because where IV antibiotics may be required or further investigation may be required since oral antibiotics is not working on the patient's infection. It also increased the risk to society on antimicrobial resistance, and we are all aware of the antimicrobial stewardship. This leads to clinical management problem in wound management and also a higher risk of mortality due to sepsis. So textbook criteria for signs and symptoms of infection are very important, but do they always help to manage or identify early diagnosis of infection? Some of these textbooks criteria that we all know about is heat, swelling, redness, and pain. But remember, not all patients show the normal signs of infection. Hence, we do need to consider other symptoms also that will be able to guide us whether there is infection or not. Pain, erythema, abscess formation, delayed in healing or the wound breakdown itself, confusion in the patient, some changes in the granulation tissue where it can get darker or it can just get, a bleeding on contact, more friable. We can get cellulitis, increased malodor, some induration or edema at the wound edges. And we also have got exudate, which is a really good indicator in wound infection. It may change in color from serous to amber to milky or creamy thick exudate. The texture may change from thin to thick purulent discharge, and the amount may increase unexpectedly. When I mentioned changes in granulation tissue, remember we also got the hypergranulation and you're very friable that bleeds on contact. So this is the reason why as clinician, we should not just rely on the textbook criteria for infection checking, but also about believe in your eyes, do your assessment, and also make sure if you have got in your trust the National Early Warning Score, which is called the NEWS score, a very valuable tool to use in terms of assessing deteriorating patient as well. So as clinicians, we are always led by guidelines, national guidelines, international guidelines, or published documents which help us to know how best can we do our job. And this is a really good indicator for us clinicians to know how do we manage wound infection in clinical practice. As you can see, it is principles of best practice. So this is the second edition of wound infection in clinical practice. It was first published in 2008 by the World Union of Wound Healing Societies. The original document was authored by leading experts in wound management, and it was endorsed by the World Union of Wound Healing Societies. The intent of this edition is to provide us a practical, updated resources that is easy to use and understand by ourselves, clinicians on the ground, and is also the most up-to-date version. We are hoping to get a revised version of this document in 2022. From this document, the guidance for practitioners is to understand the different stages in wound infection continuum up to spreading infection and when to act. So these are the stages that's described into that document. And as you can see, there are 5 stages that leads up to wound spreading infection in a wound bed. So you've got contamination, and this document tells you where there is contamination, you do not need antimicrobials. It's only vigilance required. And colonization, local infection, spreading infection, and systemic infection. We're going to look at each of them. As I mentioned, this document helped myself as a clinician and other clinicians in wound management to differentiate between the stages of contamination right up to infection and accurately manage them. So contamination, what is it? It's the presence of non-proliferating microbes within a wound at a level that does not evoke a host response. So basically, it's there, but it's not causing any impact on your wound. Virtually from the time of wounding, all open wounds are contaminated with microbes. And remember, you should not be treating with antimicrobials for contamination. The next stage is colonization. All chronic wounds are colonized up to the point of healing. That's your leg ulcers, your pressure ulcers, your diabetic foot ulcers. Colonization is when the microbial species successfully grow and divide, but they do not cause damage to the host or initiate a wound infection. Colonization, it refers to the presence within the wound of microbial organisms that undergo limited proliferation without evoking that host reaction. So you do not get that host reaction in the wound bed. Yes, microbial growth will occur, but it's at a non-critical level, and wound healing is not impeded or delayed. And again, the guidance said, do not treat with antimicrobials for colonization of wounds. The next one is what we call local infection. I'm sure most of us have seen this color. Local infection, wounds will not heal despite standard care. It can be painful. It can have strike-through or secondary dressings. And local infection is usually contained in one location, the system or the structure. What happens in local infection? The infection occurs when bacteria or other microbes move deeper into the wound tissue and proliferate at a rate that invokes a response in the host. So as I said, it's contained in one location. So it can be present in 2 types. The covert signs, which is the more subtle signs where you can get something like a hypergranulation, which is excessive vascular tissue, bit of bleeding in the wound bed, or some friable granulation. You might also have some bridging or pocketing in the granulation tissue, or you might have it as some overt signs, some more covert signs of infection as purulent discharge, delayed wound healing, beyond expectation, new or increasing pain, increasing malodor, or also some wound bed breakdown or enlargement. So this one, as you can see from the guidance I showed earlier, antimicrobial is very effective. And then we have what we call spreading infection. Spreading infection, it involves It may involve deep tissue, muscle, fascia, organs, or body cavities. Remember, in spreading infection, it's the invasion of the surrounding tissue, and the microorganism proliferate and spread to a degree that the signs and symptoms extend beyond the wound border. Hence, you can see in the photograph that the infection extends beyond the edges of the wound. The wound breakdown happen. It may have dehiscence with or without satellite lesions. Patient can report of malaise, lethargy, non-specific general deterioration, loss of appetite, inflammation, or swelling of the lymph glands. And again, antimicrobial may be useful for that one, but the guidance is there to support us. And the final one is systemic infection. And we've all seen at some point a patient who are systemically unwell and have got an infection. It affects the body as a whole, with microorganisms spreading throughout the body via the vascular or the lymphatic system. The systematic inflammatory response can be as severe sepsis, septic shock, organ failure, or organ dysfunction, or even death. And this is the reason why very often, as I mentioned on the textbook criteria for signs and symptoms of infection, we also need to look further beyond these criteria and check your patient for general deterioration. So now that we know the classification, we've assessed and identified a wound as being infected, how do we treat them? Again, we are guided by local and national, international policies and guidance. Systematic antibiotics can be used. However, they should be reserved and appropriately used. Remember, judicious use of antibiotics is reserved for wound infection confirmed by clinical signs and symptoms or confirmation by microbiological inquiry. Or you may use topical antimicrobial agents, which is very useful in managing bioburden and reducing biofilm. Or you may also use non-medical medicated dressing as an alternative to manage wound bioburden. So as a tissue and viability clinician in the community, what kinds of wounds do I see? So the wounds that we see, or my team and myself, I see in the community is just some of them: moisture lesions, skin tears, surgical wounds, fungating wounds, trauma wounds, pressure ulcers, leg ulcers, diabetic foot ulcers, burns, including radiotherapy burns. But we also see both adult and children. So we see wounds in both the category of patient. So as I mentioned, clinicians, we are very well supported to deliver clinical practice and managing wound care in the community or in our settings. This document, again, there's a section of it that tells us how to manage the infection using antimicrobials. And we are all worried about antimicrobial resistance. And this is the reason following guidelines sometimes is very important. There are so many antimicrobial agents that you can see has been labeled here. We've got iodine, and we all know inidine, iodine, we've got honey, we've got silver, we've got the ionic silvers, we've got surfactant. So surfactant, it could be in the form of, if you know it, more commonly known as prontazan or octenolin, but we also got in the right on the top there, we've got enzyme alginogel. And today's session is going to be focusing on enzyme alginogel as an antimicrobial. So the enzyme alginogel that I'll be focusing mostly is what we call FLAMINAL. So what is FLAMINAL? So FLAMINAL is, as I say, an enzyme alginogel, but it's also a debriding gel. It's also an absorbent alginate and an antimicrobial system enzyme within the system. How does it debride? The gel dissolves the necrotic tissue or your sloughy fibrin, and it also absorbs them from the wound bed. And how does it absorb being an alginate? It has some absorbent alginate that helps with the absorption of debris, bacteria, and excess exudate. It contains an antimicrobial enzyme that protects the wound against microbial colonization and infection. So what is FLAMINAL? So thanks to the enzyme system in the FLAMINAL, reactive oxygen species are formed, which are able to destruct the microbial cell wall and kill the potential wound pathogens. The antimicrobial mode of action of FLAMINAL takes place within the alginogel structure. Therefore, FLAMINAL does not destroy healthy skin cells. But can FLAMINAL be used in all part of our wound bed preparation? Because we do know to get maximizing wound healing process, we need to get our wound bed right. Yes, they can. And that's the answer to our question. FLAMINAL can be used in all 5 aspects of the TIMES paradigm, and that's in your tissue, in managing infection and moisture, on the edge of wound, and as for your surrounding skin. For the type of tissue, it promotes a continuous autolytic debridement. So it debride our non-viable, non-healthy tissue. We have just looked at the antimicrobial protection, which may reduce the bioburden in the wound bed. And M for moist wound healing, it also absorbs excess exudate. Edge, we know that it's non-toxic, so it's safe for the skin and skin tissues, and it also protects the wound edges from excoriation or maceration. And surrounding skin, again, it doesn't cause any damage to the surrounding skin. So now I'm going to show you some case studies in relation to this enzyme alginogel, FLAMINAL, and the different types of wounds, the versatility of the product where it has been used in practice. So my first case study will be on a patient who is a 50-year-old female with still unemployment. She had MS, multiple sclerosis, and she was wheelchair bound. She was originally referred to tissue viability in the community with a Cat 4 pressure ulcer to her left buttock. This one on first assessment had a high volume of exudate, malodor was quite high, and she had no pain, hence she didn't even know how it developed so quickly because obviously she's got MS and no feeling down below. So the wound when we have first see, as you can see from the wound bed and the picture, it was a combination of slough and unhealthy granulation. The bone was palpable and the surrounding skin, although looks unaffected, it was very fragile. We have tried using a hydrofiber to pack, but because of the high amount of exudate, the hydrofibers was jellified so quickly, and this lady was having several SOS call out. So she was having daily visits anyway by community nurses, but at the same time, she was having to call out in the evening because the dressing was soaked and saturated. It didn't work for the patient. She was very unhappy. And because obviously the wound wasn't healing and the dressing wasn't being maximized, she wasn't happy to spend more time in the bed because that leads to poor quality of life. Her aim was to get back to her independence, her working, and live her life as she used to. So working with the patient, the aim that we figure out was to how quickly can we reduce the slough, bioburden, using a dressing that she won't have to call out SOS, manage to exudate more effectively, but at the same time improve her quality of life. So we started her on FLAMINAL, which was an enzyme alginogel, in the thing that we can manage both the slough and the exudate at the same time. And clinicians, we love pictures. We do like to see what's happening. Yes, this is the result 4 weeks later. There was no slough. The exudate was more controlled. The bone wasn't palpable or visible anymore. Patient is more confident at that point because despite she was still sitting out for that restricted time that we told her, she could see the improvement. So she was a bit more concordant and looking forward to something. And a few months later, as we know, chronic wounds, they don't heal overnight. But remember, our aim was ensure holistic approach. It's not just the dressing, it's everything else regarding the skin, but the impact the dressing, the gel has caused on the wound is what matters really to the patient. Because that wound care was very patient-centered, and she saw the treatment regime with another product that didn't work. And when she saw the improvement with this one, she decided to concord better. So a few months later, and as I can say, she's now completely healed. So again, case study shows how your wound care should be always patient-centered, involving your patient and holistic at all time. The next one is a lady which had a fungating wound, 93-year-old, who was still very independent with all her activities of daily livings. She had atrial fibrillation, she had hypothyroidism, hypertension, but she did develop a squamous cell carcinoma, which was spreading to the left side of the face. And we know fungating wounds do not heal like that. So the aim should be manage the symptoms that causing the most trouble and most discomfort to the patient. Looking at the picture, you can see, and I don't need to tell you how thick and high volume of exudate was coming out of it. It was very malodorous. The surrounding skin was affected, it was friable, and every time she washed her face, the towel or gauze or whatever she was doing was getting on the scab, and she was having loads of severe bleeds. We've had several large bleeds in the community with her, and several times 999 had to be called as we couldn't get that stop in the community. So when she was referred to me again, the patient was not willing to have any palliative treatment. She was, as I said, she was still very independent with her activities of daily living. She lived with her grandson, who was very caring. And her aim, when I asked her what she wanted most for me to achieve for her, her aim was reduce the odor, stop the exudate dripping on my face so it doesn't kind of stop me eating and disturb my life. So that was my aim. My aim was never to heal the wound. My aim was what the patient wanted it to happen. So how do we manage these friable areas more effectively, but at the same time reduce the exudate and the malodor? Because I know this will improve her quality of life if I get that right. This is where we started on the enzyme alginogel. And for this case scenario, we started her on FLAMINAL forte. As I mentioned to you, the grandson was very involved, and unfortunately, it was during the COVID pandemic first wave. She or her grandson wasn't keen for nurses to attend regularly because of the fear of COVID and infection. So what we did, and this was a big part of tissue viability work at that time, how we can empower family, relatives, patient, or carers to do self-care. We worked with the grandson who wanted to do something for the patient. So it was very easy because there was engagement from both the patient and the grandson. I taught him how to do simple wound care. We used a self-care booklet and step-by-step document everything he had to do, and also showed him how to clean it gently using an antimicrobial without rubbing, not to disturb any scab, just to dab it gently on the face, and also to apply the FLAMINAL forte daily on all areas. But the beauty with FLAMINAL forte is no secondary dressing was required. And because it doesn't leak like any other gel, it will stay on the wound. And obviously why I chose forte, because remember the alginate content make it more absorbent. And at the same time, the antimicrobial reduce the odor. But I had to be also realistic for what the family can do and what really matters for the patient. And this is the reason that was a dressing of choice for the patient. 2 weeks after, the scab had gently come off together, but there was no bleeding. The malodor was completely reduced. And why I said 2 weeks, anybody that I put on self-care, I made sure they were followed up and reviewed after 2 weeks. We don't just say, here you go, here's the plan, off you go. We have to make sure we're there to support them. And if they need us before 2 weeks, they knew how to contact us. There was minimal exudate or leaking on her face. She was better as there was no malodor anymore. But the most important part was after another extra 2 weeks, 4 weeks after the treatment, the eye was cleared and slightly open. When I attended the patient, she was actually watching TV, which was really emotional. And both the grandson and the patient were in tears. And you know, us nurses, we do get emotional very quickly as well. So yes, I was as well. But for me, what was important is her aim has been achieved. There was no exudate. Her quality of life was better because she was able to get on with things that she loved doing before that has started impacting. So obviously she's not on our caseload anymore, but the family knows that if there is any issue, how to manage it and how to contact us, because she's now back to her normal self and normal activities. My third case today is about an extreme case of moisture-associated skin damage. And this is where it's really important to remember patient and carers are key to the care plan. You cannot do something for them. You've got to do it with them. So this was a patient who was 87-year-old, type 2 diabetes, hypertension, had disc fusion, reduced mobility, had recurrent falls, and as a result, needing 2 people to transfer safely from bed to chair using equipment. She had really bad moisture-associated skin damage, which was being managed by our community nursing team. All appropriate skincare regime was given to the carers. However, the patient developed a really bad episode of loose stool for 1 week, and that skin had rapidly deteriorated after that episode of loose stool. And as you can see, the skin became very fragile and affected. And from that, it leads to reduced appetite, low mood, very low motivation because of the possibility of getting worse, developing into a pressure ulcer. That patient was asked to stay in bed longer than what she used to be before. So she used to sit out for all her meal times, which she can't do anymore. She loved doing her knitting, which she can't do anymore. So at that time, this is where we involved the carers with us because they were visiting 4 times daily. And our aim was, how do we improve the skin integrity, but at the same time, make it easy of application for the carers because of how frequent her incontinence was. So the aim was, again, to improve not only her quality of life, but improve her appetite, her mood, which in turn will improve her motivation, and that will lead to better concordance and further prevention. So, and we started her on enzyme alginogel, which was FLAMINAL 40. What we did, we advised the carers to use a pea size of the gel 4 times daily, or at each carer's call, and only use 1 pad to limit pressure and to make sure that, the skin was breathable. We ensured that they were not applying any secondary dressing so that they could monitor, wash the skin gently, pat it dry gently, apply the FLAMINAL there. 4 weeks later, that was the outcome of it. So the bleeding had stopped. As you can see, the skin integrity looks so much better. She was sitting out on appropriate pressure relief cushion to prevent pressure ulcer at all her meal times again. But she also understands the importance of offloading because the skin was still a bit vulnerable and prone to further damage if we're not precautious with that. So she was happy to kind of restrict her sitting. Carers, in other words, felt very equipped to look after patient, and the contribution they have made to improve the patient quality of life. They carried on with the regime, and 8 weeks later, this is what the outcome was. So as we can see, that was the final outcome. Beautiful epithelial tissue, healthy skin there. Yes, still fragile and vulnerable, but that's where you go back to your barrier cream, making sure you use your proper MAST skincare. And why did we choose FLAMINAL 40 for managing that moisture-associated skin damage is because of its antifungal properties. Yes, we've talked about FLAMINAL being antimicrobial, but unlike other barrier cream, where you will have to use an antifungal jointly with the barrier cream where there's incontinence or fungal infection present, FLAMINAL 40 has both properties in its component. Hence, it was easier for carers to use and for self-care. Remember, FLAMINAL is an antifungal as well as antimicrobial, and it's great against candidiasis, which is common in moisture-associated skin damage, moisture lesion for short. The GLG enzyme in FLAMINAL has no recorded antimicrobial resistance, unlike most topical antibiotics or antiseptics. FLAMINAL is non-cytotoxic, meaning cellular growth is not impaired when used. Therefore, wound healing will be much quicker than all other topical antibiotics and antiseptics. And remember, FLAMINAL has a shelf life of up to 2 years or the expiry date, whichever comes first. Therefore, for clinicians like myself in the community, it is very cost effective. And the fourth case scenario that I have tonight is a diabetic foot ulcers. This patient, who was 64-year-old male gentleman, type 2 diabetes for over 15 years, ischemic heart disease, nephropathy, retinopathy, and peripheral vascular disease. He had the diabetic foot ulcer following a neuroischemic amputation of the left forefoot and high volume of exudate, as you can see in the picture. The wound had very deep slough with a mixture of necrosis and slough in there, encompassed the whole of his forefoot right down to the bone. The surrounding skin looks unaffected, but very fragile and prone to damage because of the exudate. So the aim for this patient was, again, deslough, reduce the bioburden, manage the exudate more effectively, and just manage it with simple dressing to keep the wound covered. In this case scenario, again, the enzyme alginogel was used to start desloughing and managing the exudate more effectively. And as I said earlier, chronic wounds do not heal overnight. That was in May 2013, after continuous use of the FLAMINAL Forte. That is what the wound looks like. And as I say, we love pictures. In June 2013, that was the outcome. So you can see the treatment plan was to reduce slough and bioburden, maintain that healing process, and also manage the exudate more effectively. But due to the complex nature of this patient and health and vascular status, the hope of starting FLAMINAL Forte was to how do we reduce that slough and manage the exudate more effectively to prevent the wound from further deterioration, which was achieved. And later on, a few months after, this was the result. So the emphasis is the FLAMINAL has caused repeated debridement, as we saw in the debriding gel properties. It has also led to bacterial control. It's basically has demonstrated its effectiveness on continuous wound debridement, antimicrobial activity, maintenance of your moist wound healing environment, and protecting your edges as well. So yes, FLAMINAL Forte is also suitable for diabetic foot ulcers, as it's indicated for moderate to highly exuding wounds. So why did I choose FLAMINAL as my antimicrobial today for the session? So as I say, I look after both children and adults. And for me, FLAMINAL has proven to be versatile. 4 different case studies, I've been able to show you the different types of wounds that I have used it successfully. Most recently, we've seen an increase in fungating wounds in the community, and FLAMINAL has been one of my first dressing of choice. Reason being, its multiple properties of managing odor and everything, but at the same time, it offers the potential for patient or carers to self-care and or shared care. And this is really important if, you're having, especially like now with all the pandemic and everything, not everybody wants a nurse in their house or want to attend a GP surgery for dressing change. So this is one of the reasons. So just to summarize, FLAMINAL offers antimicrobial protection. It also offers a minimal risk for resistance development. While it's debriding, it's also removing your necrotic tissues. Very good if you're self-caring or shared caring with patient and relatives. And it's ease of use because in patient who has got perianal abscesses, pilonidal sinuses, or very hard to reach wounds, we know how painful it can be to pack using a hydrofiber and a probe. So the use of FLAMINAL can be very easy and pain-free. And as we know, it's not cytotoxic. So that means for our skin tissue, it's very safe. It protects our wound edges. Most importantly, we know for wound to process to healing, we need a moist healing environment. It gives us that nature, and it also manages our exudate most effectively. If you haven't used FLAMINAL, give it a go. Don't be scared, because this is the chance to go for innovative products if you haven't been able to do it. If you don't know how to choose your product, the company has been very useful when we introduce it on our formulary. There is a staff video that they can share, and that staff video, it's literally 2 minutes, but what it does, it tells you about how to choose the appropriate product, because it comes in the version of FLAMINAL Hydro, where it donates moisture, or FLAMINAL Forte, where it absorbs. So this is the reason why, if you haven't used it, give it a go. And if you would like to try it, I would suggest get in touch now with your company representatives, and I'm sure they'll be more than happy to support you with any queries or questions they may have. I really hope this session has helped. These are some references. I thank you all for your time, for listening to me today. And if you do have any questions, Sam and myself, we are here for you. Thank you.
Sorry, I was muted there. Thank you so much, Luxmi. That was an absolutely fascinating presentation. Some really amazing case studies as well. So I've been keeping an eye on the comments and questions coming through. We've had lots and lots and lots come through, so I'll move straight on to those. I will just say to everyone watching, if you want to find out those contact details or want to look back on any of the slides at any point, the slides will be on our website in the next 24 hours, so you can find those under the Facebook Live tab on there. So now we'll move on to the Q&A. If you do have any more questions whilst this is going on, please keep submitting them. We'll be posting any that we don't answer onto our website along with the slides as well, but we'll get through as many as we can now. So moving on to our first question, Luxmi. How many of the signs and symptoms you mentioned would you expect to see when looking at an infected wound?
So as I showed in that presentation, especially if people want to follow the guidance from the document that I showed, definitely more than one. And depending on the stage of infection, I will also look at the wound bed and consider patient's observation. For example, your increased pain, exudate type, texture, bleeding, etc.
Brilliant. Thank you very much. So question 2 is, how does an enzyme alginogel protect the wound against microbial colonization and infection?
Thanks to the enzyme system in FLAMINAL, which is the reactive oxygen species are formed, which they are able to destruct the microbial cell wall, so it kills potential wound pathogens. The antimicrobial mode of action of FLAMINAL takes place within the alginogel structure. Therefore, FLAMINAL does not destroy the healthy skin cells.
Fantastic, thank you. And now question 3 is from Charlotte, who's been watching tonight. What would you use with the FLAMINAL for a secondary dressing?
It depends on if you have to use a secondary dressing. I would also, you can always use a foam as a secondary dressing. But as I say, the FLAMINAL itself, it's not something like a gel that will be leaking or anything. So if it is, depending on the anatomical position of the wound, I would go for something that will keep it in place if needed. Otherwise, just a secondary foam dressing is fine.
Perfect, thank you very much. Question 4 is from Susie. And Susie asks, would you recommend an antimicrobial dressing first instead of antibiotics if there is more than 2 increased markers?
Definitely, definitely I would, because obviously we do know our patients better, and assessing your patient, and always trust your eyes. If your patient is systemically well, you've got the 2 signs, but your patient is well, but you also search to let it's local infection, I would always start with my antimicrobials and monitor my patient closely.
Brilliant, thank you. Question 5. With regards to the case study with the fungating wound, you mentioned that the grandson was involved in the simple wound care. How often do you see shared care being part of a treatment plan at the moment, and how do you manage to support the family or carers with that?
I believe, obviously, since the pandemic, we've learned a lot from it, but every patient should be considered for shared care at initial assessment, if to assess if that's a possibility, because I have learned from experience that it not only empowers the patient but also the family and the carers to be fully involved in the care. And when they're taking a responsibility for the wound, it's that partnership working. How do we support the family and the carers? As I said in my case study, we use a self-care booklet that was published by NHS National Wound Care Strategy. And that's a shared care booklet. You can document the red flags. You can document basically using simple terms what you want the patient, the family members to look for, the step-by-step taken to clean the wound, how to apply the dressing, and also like when they're changing, what they should be looking for, signs to report to you. How do I also support them? I always keep an eye on them, at least fortnightly, but they do know that if there's anything earlier than that, they can contact us.
Brilliant, thank you. So question 6 is, can you use FLAMINAL across the whole wound infection continuum scale?
As a tissue viability clinician, I would follow the guidance on the infection continuum. If you look at the in continuum, it does tell you for contamination and colonization, you just need to be vigilant, but you don't need to use antimicrobials. it very clearly guides us when to use an antimicrobial. So I would use an antimicrobial agent with caution and appropriately. But yes, you can if need be.
Fantastic, thank you. Question 7, can you describe your idea of the perfect antimicrobial dressing, and does this change depending on whether you are treating an adult or child?
As a TVN, again, be it a child or an adult, we need to make sure we're always putting best practice in place and evidence-based practice. So remember, some topical antiseptics or antimicrobial are non-selective and can be cytotoxic if it's not delivered to the wound in a sustained manner. So for me, the perfect antimicrobial should be non-cytotoxic. It should be a product with a sustained release of antimicrobial agent at a concentration low enough to minimize toxicity, but still able to destroy or inhibit that bacterial or fungal growth. And at the same time, it should be that product that will prevent the formation of biofilm or inhibits or establish biofilm in a wound.
Great, thank you. Question 8 is from Michelle. Michelle asks, can we still use FLAMINAL after 2 weeks?
Yes, you can. And there is actually, many clinicians recommend the use of a 2 weeks challenge with any antimicrobial, as this allows sufficient time for the topical agent to exert a beneficial activity. There is also the practice of alternating rotational topical wound therapies, and this has gained popularity among clinicians, especially in the community. I think the premise for this strategy is not well researched, but it's that the idea behind it is that the suppression of a range of microbials is attained through the application of a different topical antimicrobial in a 2 or 4 week rotations. So research has suggested that alternating the type of antimicrobial applied to the wound may assist in the restoration of microbial balance, but it's also what you see in clinical practice. And as you saw from my case studies, we have been able to use FLAMINAL Forte for longer than 2 weeks. We've not got resistance, but we've still got the end product, which was safe and healing.
Fantastic, thank you. Melanie asks, a patient with multiple allergies to silver and has had issues with Pseudomonas infections to lymph eczema to the leg. Do you have any suggestions?
So definitely if they're allergic to silver, I'll be cautious in using other antimicrobials. And I have used FLAMINAL on patients who have got previous sensitivity to either like honey or iodine, and they were safe using FLAMINAL. So I think it will just be a matter of either you patch test them before you use them, or just make sure your allergies history are accurate. And I would suggest, again, as a nurse, I would do a patch test, which I have done so many times in patients who have reacted to iodine in the past and have reacted to silver. And when I've used the gel on them, there was no reaction. So I use it safely on Pseudomonas as well.
Fantastic, thank you. Question 10. There are so many antimicrobials to choose from. How do you decide which to use, as every wound is so different? And at what point would you step down from using it or swap to another?
I think it's very essential that, you know, we remember most healing wounds do not require the antimicrobial therapy. So as a clinician, it will be reassessment. And as I said, there is that, you know, the clinician's recommendation of a 2 weeks challenge. So I think reassessment every 2 weeks is very important, because this is based on research as well, so that we can continue to get the beneficial activity of the antimicrobial. And we know in practice, silver cannot be used more than 2 weeks, for example. So in my clinical practice, if we feel that antimicrobial is still required and silver has done the job, we will always step down to another antimicrobial to continue the antimicrobial activity. So we will stop the silver and step down to another thing. And the document tell you there's about 5 or 6 antimicrobial agents. So this is where your decision making should be purely based on what your clinical findings are, whether you still need it or not.
Okay, thank you. Question 11 from Arlena is, can we use FLAMINAL with diabetic patients?
Definitely. And I think case studies speak for itself. And we use it both in diabetic foot ulcers and patient with diabetes with other wounds. So yes, it is safe to be used.
Brilliant, thank you. Question 12 from Carolyn. This particular wound is colonized but had green exudate. How do I proceed?
So again, I have showed you that the chart, the wound infection continuum does show colonization. But remember, if you do not treat colonization or you're not vigilant with it, it will step up to the local infection. So yes, I would suggest if you feel your signs or the wound is stagnant, so if you do need to use an antimicrobial to decolonize it, do it then to prevent the further stepping up as local infection.
Brilliant, thank you. And thank you everyone for all your questions. Some really interesting questions so far. We've still got some time to get through a few more, so I'll move on to question number 13. I think we're on. What are the signs and symptoms of antimicrobial toxicity?
Skin rashes. Definitely skin rashes. And obviously, if you're putting something, we've seen patients who react straight away when you put something that they react with, for example, silver, they come up with hives. Some can also have an anaphylactic shock. So you have to be very careful. And if you're not sure before you put any dressing or gel on the patient, this is what I always recommend, a patch test. And we've also seen some cytotoxicity where the wound itself will there will be like that burning sensation when you're applying it on the wound bed. The patient is the best one to tell you what they're feeling right then and there. So obviously it's your eye, your observation, but what the worst I have seen is anaphylactic shock.
Okay, brilliant, thank you. Question 14, can we use FLAMINAL on MASD?
I think my case study has already replied to that, and this is working very well, where we have seen an increased use of FLAMINAL 40 on really severe MASD. When the moment it's healed, we step them down back to the barrier cream. It works brilliant. So instead of like letting it deteriorate to further, what we do when it's as excoriated as you saw in my case studies, yes, don't wait for it to get worse.
Fantastic, thank you. Question 15 from Debbie. How do we as nurses educate carers and other nurses or GPs not to rely on a wound swab?
This is my daily routine and I'm not stopping it because I keep telling them. And the best thing to do is use your diagram on the contamination, colonization, and also your signs and symptoms. Because very often I know for clinicians or GPs who say or do that, and as soon as they see slough, they prescribe 2 weeks of antibiotics. Remember, slough is not infection. So I think this is where, as nurses, we are more powerful in our education. So go out there and talk to them about colonization, how the wound gets biofilm, act on it, and use your antimicrobial knowledge that you've got, your antimicrobial guidance that you've got, and just make sure that is shared out and loud.
Brilliant, thank you. And this may be the last question, question number 16 from Daniel. Is FLAMINAL available for podiatrists?
Yes, it's available on FP10. I know our podiatrists use it, and you can also buy it over the counter. But as I say, if you want more information, get in touch with the people who is for your locality. They will be able to give you loads of information of it, PIP codes if you need to prescribe it, or how to obtain it.
Fantastic, thank you. And we've actually had another question come through. This one's from Lisa. Would you use it for infected surgical wounds, i.e. C-section wounds?
I have used it. I have actually used it on a dehisced surgical wound. And it was actually an abdominal wound. And yes, it has worked really well. And thank you, Lisa, for this question. I was meant to put a case study, but obviously I had to be cautious of how many I can. And just to say that patient actually had a really massive dehiscence, very red erythema around the surgical wounds, but you could also see that gaping where it was bubbling out fluid. What we did, we used a syringe, we inserted the FLAMINAL in there. So, and wound healing need to happen from base up. And this is where we've been monitoring. What we did, First time we started with 5 mils of FLAMINAL into the cavity. And then gradually we realized that we were only putting 1 mil. So for us, that is an indication that the base was coming up. But most of all, the erythema, the pain and everything had reduced. The exudate had reduced and she healed beautifully. She didn't need to go back in hospital for review of that surgical wounds.
Great, thank you. With a few more questions actually now. So Fenella asks, are there any issues of allergic reaction using it?
I think FLAMINAL for me as a clinician, and I'm going to talk about personal experience, I have used it in patients' mouth, on the eyes, in children, in adults. And also I have also made sure I had done my work with my, educating myself from the company. And I know that it has got that natural enzymes in it. So it hasn't had any reaction or side effects. But as I say, not every patient are the same. So if you are worried, as I say, the company will have more information for you. But I can only tell from my personal experience with it.
Yeah, of course. And thank you very much for that. Question 19 is the final question. We've had lots and lots of questions. So thank you so much for answering all of them. Your insights have been amazing. So thank you so much. So the final question is from Claire. And Claire asks, do you apply FLAMINAL daily?
If need be, as you remember, I talk about the MASD patient. So in her case, yes, we had to do it like because she had very bad loose stool. So we did it even QDS on her skin, but this is where education is key. You don't use a whole tube, you use a pea size. And that's where it's really important to educate your carers or whoever's delivering the care. So a pea size 4 times a day, reviewed after every week, and you saw the difference it make. And if you are using it for perinodon sinuses or perineal abscesses, yes, it's daily application because of the place that it is. You have to make sure of the hygiene of the patient as well. They will want to have daily shower. So we recommend them to apply it daily. But if it is on a surgical wound, then no, you don't need it daily. And obviously it depends on where you are using it as well.
Fantastic. Thank you. Thank you, Luxmi, so much for your presentation and your time this evening and all those answers to the questions. Thank you, everyone, for submitting the questions and for watching tonight. We've really enjoyed going through some of them. As I said, if we haven't got through to yours, we will try and answer those in the next few days and post those answers along with the slides and the certificate link on our website. Thank you to Flen Health as well for supporting tonight's event. To get in touch or request a free sample from them, please visit their website on flenhealth.co.uk, or you can also email them on info@flenhealth.com. So those contact details should be on the screen. They should also be posted by one of my colleagues in the comments section. The certificate link now should also be on your screen. You'll be able to download that for your CPD hours. That will also be in the comments section. Yeah, we'll be back soon. I think we've got a short break for a few weeks now, but keep an eye on our Facebook pages. Make sure you're following, and we'll see you for the next one. Thank you very much.
Thank you, Sam.